Now, this is the potential indirect cardiovascular effects of GLP-1 receptor agonist. It helps to increase the utilization of the glucose, along with the reduction in the fatty acid utilization, infarct size, coronary flow, LV ejection fraction is improved, and increase in the myocardial salvage index. So I'm not going to the detail, but it acts on different target sites like pancreas, intestine, kidney, hypothalamus, and adipocytes. Semaglutide, you all know that GLP-1 receptor agonist, it reduces the cardiovascular risk in overweight and obese patients, improves weight and heart failure symptoms in patients with heart failure with preserved ejection fraction or type 2 diabetes. And the conclusion is that these data support the use of oral semaglutide across a broad spectrum population of patients with type 2 diabetes in combination with other commonly used glucose lowering agents. So if you focus on this particular slide, that the primary composite endpoints, the non-fatal stroke, the non-fatal myocardial infarction, death from cardiovascular causes, all are reduced. Only there is a small increase of non-fatal MI with oral semaglutide in the study. This is the second uppermost middle picture slide. And there is also definitely a robust evidence of body weight reduction and control of the blood sugar. The dual GLP-1 GIP agonist tirzepatide, the dose is 2.5 subcutaneous once weekly, and then to increase the dose 5 mg weekly can be escalated to 15 mg. Side effects are mainly gastrointestinal, and the primary endpoints are change in A1C level from baseline to week 26, and HbA1c. There is secondary efficacy endpoints, changes from baseline in the fasting blood glucose, plasma concentration, and the BMI is improved. So this is the SURMOUNT-1 trial involving the tirzepatide, where change in body weight is to the tune of 20%, and change in waist circumference to the tune of 18.5. So these are the different trials. I am not going to the details. You all know these trials. The Emperor trial, Emperor reduced, declared TIMI. The main point here is to focus on that all the composite CV death, non-fatal MI, non-fatal stroke are there is definite improvement as analyzed from time to first occurrence. So SGLT2 is the next. That SGLT2 inhibitors modulate several key CV risk factors. But the direct mechanism of cardioprotection is still unknown, maybe due to lowering of the blood pressure, arterial stiffness, taking care of albuminuria, taking care of uric acid. Then weight, definitely there is a weight loss to the tune of 3 to 5 kg, and taking care of insulin sensitivity. And this is the final outcomes. The use of both GLP-1RA and SGLT2, as we all know, associated with significant 13% and 16% rate reduction in CV death, respectively, with non-significant heterogeneity for GLP-1RA. These are the different studies. Apart from cardiovascular benefit, there is also a sustained decrease in the progression of renal insufficiency is halted, or the duration is increased, and there is also decrease in the albuminuria progression by different studies involving SGLT2 and the GLP-RA. Now, patients and clinical preferences and priorities for considering SGLT2 versus GLP-RA may be for weight loss, it is the GLP-RA, as you all know, and the MACE prevention equal for both heart failure prevention. If it is the main goal, then SGLT2 will get priority over GLP-RA. Renal progression, again SGLT2, and overall both are actually complementary to each other. So blood pressure management is another important area. Strict control of the blood pressure by different association. It should be like 130/80 or less. ADA though has recommended the blood pressure goal to the tune of 140/90 or less. But if there are the blood pressure is above target, then there is indication for dual antihypertensive therapy. And the first line agents are diuretics, ACE inhibitor, ARB, and calcium channel blockers, as we all know. Correction of dyslipidemia, lipid lowering drugs, we all know the conventional drugs. The newer agents are PCSK9 inhibitors, bempedoic acid, and inclisiran, and these are the class of indications. I am not going to the detail. Twice a year inclisiran lowered LDL-C by more than 50% safely, and it is a very safe drug except some local site injection site reactions. So, and let us focus on this slide, who are the actually target population who are very high risk, like diabetes with target organ damage, diabetes with 2 or more major ASCVD risk factor, calcium score, more calcium scores, and very high risk groups are patients with ASCVD with 1 or more features of very high risk group, or recurrent ACS, or polyvascular disease, or patients suffering from familial hypercholesterolemia. So in those patients and also patients who are having low risk, one should go for high LPL level, may indicate the need for more intensive statin therapy to optimize the patient's LDL level and reduce their risk for coronary disease. And PCSK9 inhibitors are an option for lowering LPL level other than statin. A meta-analysis showed PCSK9 inhibitors lowered LPL level by more 26% in addition to improved cardiac outcome. So the take-home message is reduction in diabetes complications in the form of strict control of the blood sugar, blood pressure, proper lipid management by conventional along with inclisiran or a monoclonal antibody like evolocumab, and also agents that will reduce the cardiovascular, improve the cardiovascular and the kidney benefit, and reduce the mortality and morbidity like SGLT2 and GLP-RA in the injectable form. And also there is ongoing trial on oral semaglutide in view of the, other than weight loss, is how much it will be beneficial for cardiovascular point of view. Thank you so much.
Excellent talk. Due to paucity of time, we will only permit 2 questions from the house. Any query? The topic is open for discussion, please. Dr. Amit Dey, I am sure you will have something. Okay, thank you.
Thank you, Chairperson, sir. And again,
thank you so much.
The organizer for hosting such a wonderful conference. Is there? Yes.
One question.
Yes, sir.
So in this era of GLP-1 receptor agonist and SGLT2 inhibitor, so as you have highlighted in your last slide that one of the important component of glycemic management, glycemic control. So would you prefer the early and intensive control with any class of drug versus using GLP-1 receptor agonist or SGLT2 for prevention of complications?
Yes, yes.
For primary prevention.
Right, right. So if you compare the previous guidelines versus the recent guidelines, ADA or AHA, ACC, though you should, there is a clear leverage of the use of SGLT2 and GLP-RA over other drugs. So younger patients with history of, every patient is basically has to be individualized, and patients with high risk factors like premature coronary artery disease or patients with obesity. So you have to take care of those things, and probably SGLT2 and GLP-RA is the best, followed by combination with metformin. So that is my take. Thank you very much.
Thank you so much. Now may I take this opportunity to invite last speaker of today's session, Dr. Pratap Jethwani, and he would be speaking on diabetes in young, newer insight. Let me also inform you that Dr. Jethwani has suddenly landed all the way from Darbhanga. Welcome, sir.
Okay. Thank you, Dr. Arya. Thank you, chairpersons. Thank you, Dr. Bijoy and team DRWA for making me part of this 11th annual conference of Diabetes Research and Welfare Association. So I will be speaking on diabetes in the young, newer insights. I have no conflict of interest for this session. So diabetes in young has been classically defined as diabetes in individuals who are below 35 years of age or age of onset of diabetes below 25 years of age. And it is mainly type 1 diabetes, type 2 diabetes or LADA. And there are very few cases of ketosis-prone or monogenic diabetes, particularly mitochondrial diabetes. However, FCPD and MODY, they are quite common in this category of people. Also, gestational diabetes, particularly in females, endocrine diabetes related with various endocrine disorders, and genetic syndromes, secondary diabetes, neonatal diabetes, and last but not the least, drug-induced diabetes, particularly atypical antipsychotic-induced diabetes, particularly in the young, is quite common. So what is the Indian perspective? This is data from Lucknow SGPGI, and the most common etiologies for diabetes in young below 35 years of age. Type 2 diabetes 40%, type 1 diabetes 40%, FCPD 15%, MODY 2%, and rest are 3%. There is an increase in type 2 diabetes prevalence in our country. We all are witnessing same because of the sedentary lifestyle and the consumption of fast food items, junk food by these people, and they are spending a lot of time on the screen. They are not doing any physical activity, so their waist circumference is going high, and that is the culprit for development of young onset type 2 diabetes as well as various metabolic abnormalities. This is the young ICMR diabetes of young registry, and they have also categorized the various types of diabetes which are seen in this population, particularly in 10 to 20 years people. If you see, type 1 is still 82%, type 2 is 10.7%, MODY is around 3%, and then other are to the tune of around, totally together around 3%. So still it is type 1, type 2 and MODY, few FCPD, and then other things are quite rare, but you have to keep that in mind because the proper diagnosis in this category of people will help you in determining the treatment, and the outcomes are based on that treatment. This is the age-adjusted prevalence of various types of diabetes. I think type 2 occurs a bit late, whereas type 1 occurs quite early. MODY begins in the teens, and then it is up to 25 to 30 years of age. FCPD can occur at any point of time, but generally it is between 10 to 30 years of age. So let's start with first diabetes, that is type 1 diabetes, that is quite common in this young individuals. It is a classical type 1 diabetes. Generally the people, they present with acute onset of symptoms, few weeks history, polyuria, polydipsia, weight gain, weight loss, and if they don't give significant attention to the symptoms, they may land with vomiting, abdominal pain, presence of ketonuria, diabetic ketoacidosis, and still, if not taken care of, they may present in frank diabetic ketoacidosis, acidotic breathing, drowsiness, and may even present with comatose condition, particularly in the remote and rural areas. So presence of autoantibodies is the hallmark of this condition because it is an autoimmune destruction of beta cells. Serum C-peptide level, generally people think that it should be very low or absent at the time of presentation or in the first year of diabetes. But generally the guidelines, they recommend that for the first 3 years C-peptide may be there, it will be low, but after 3 years if there is a detectable C-peptide, then generally it is against the diagnosis of type 1 diabetes. Patients, they require insulin lifelong, not only for glycemic control but for survival also. And this is the data, recent data, persistence of prolonged C-peptide production. This was with the help of ultra-sensitive assays, and generally we feel that once the diabetes, type 1 diabetes is diagnosed like this, the C-peptide will be lowered and then it will be lost within 1 to 3 years of diagnosis of type 1 diabetes. But there are people where C-peptide may persist even up to 30, 35 years of duration of type 1 diabetes, and this is one of the data from one of the centers in USA, that C-peptide production persists for decades after disease onset, and they are trying to find out variety of genetic groups or typical genetic features of these people who have preserved C-peptide for a longer period of time, and they are trying to find out various mechanisms so that we can sustain beta cell function even in people who are losing C-peptide fast in type 1 diabetes. LADA, we all know that the patients, they present with symptoms. Initially, they respond to oral anti-diabetic agents, but they soon require insulin within 6 months of diagnosis of diabetes. So they are having very fast beta cell dysfunction, and mostly they are having presence of GATE65 antibodies. That is the hallmark of diagnosis of LADA. However, the Immunology for Diabetes Society, they have proposed diagnostic criteria for LADA. Operational age of 30 years, but still this is very difficult to determine the cutoff age for LADA. Islet antibodies generally get antibodies, but this is particularly in Caucasians, and they say that in Asian Indians, IA2 seems more important than GATE65. But currently, young age, GATE65 positivity, initial response to OHS, but within 6 months, patient requires insulin. That is the hallmark feature of LADA. And most of these people, they have got autoimmunity, other autoimmune diseases or family history of autoimmunity also. So this is the way we can identify type 1 LADA and type 2. The age type 1, comparatively younger age, type 2 occurs at a later age. Most of type 1, they are not obese. They have got a genetic predisposition, HLA-DQB1, autoantibodies are present, autoreactive T cells are there, and they require insulin treatment. If we see type 2, it occurs later on. There is obesity is definitely there. There is presence of metabolic syndrome. There is presence of systemic inflammation, and C-peptide is preserved in this category of patients, because here the main problem is insulin resistance and systemic inflammation, and LADA comes in between. Let's come to the maturity onset diabetes of the young, MODY. Nowadays, they consider it as a monogenic diabetes because it is because of a single gene defect, and they respond to variety of treatment depending on that genetic defect. So this is characterized mainly by autosomal dominant inheritance, onset before 25 years of age, absence of beta cell autoimmunity, and sustained pancreatic beta cell function. And there are 14 different genetic mutations they have been identified, and there are mainly 6 subtypes of MODY 1 to 6. The genetic mutations generally they occur in transcription factors or in glucokinase. Diagnosis, generally clinical suspicion should be high, and you have to go for genetic testing. So this is glucokinase and variety of transcription factors, hepatocyte nuclear factor, and various other factors, where genetic mutation it leads to the development of diabetes. So these are different types of MODY. If we see here, the most common are 2, that is GCK and HNF1 alpha. So HNF1 alpha is 30 to 50%. There is beta cell dysfunction, glycosuria, and they are sensitive to sulfonylurea. GCK, there is a glucose sensing defect. So stable mild fasting glucose on OGTT, postprandial will not go up after glucose challenge, whereas in HNF1 alpha, the postprandial or the post-glucose load sugar will also be increased. Here you don't require any medication, only diet is sufficient. Treatment may be required, particularly in females when they become pregnant, and if their babies, they are not having the same kind of condition. HNF4 alpha is also beta cell dysfunction, neonatal diabetes, hyperinsulinemic hypoglycemia during infancy, and low triglyceride. It is sensitive to sulfonylureas. All other are very rare, and most of them they require either OAD or insulin. So most common is MODY2, that is glucokinase, and MODY3. MODY2 onset at birth, stable mild fasting hyperglycemia generally being detected during pregnancy. Less than 50% of carriers have over diabetes. Diet treatment and very rare microvascular complications. So you need not to worry about this kind of hyperglycemia. MODY3, 58%, that is quite common. Adolescents or young adult onset, progressive hyperglycemia, progressive decline of beta cell function. They initially require diet, then OAD, and then insulin, same way like type 2 diabetes, and complications are frequent, so they are to be considered like type 2 diabetes, and everything should be done as per the protocol. FCPD, we all know, this is particularly common in our country or tropical countries. Highly heterogeneous condition, clinical, biochemical, and histopathological features are very different. To diagnose, you have to have a diabetes should be there, and then evidence of chronic pancreatitis, either pancreatic calculi on X-ray abdomen or ductal dilatation on USG or CT scan, or three of the following. This is as per Dr. Mohan's criteria about FCPD diagnosis, either recurrent abdominal pain, steatorrhea, altered pancreatic morphology, or abnormal pancreatic function tests. And you have to rule out other causes of chronic pancreatitis. And these patients, generally they require insulin. However, these people, they are resistant to ketosis because there is deficiency of glucagon also. Ketosis-prone diabetes is much more common in African American or Afro-Caribbean individuals. They present with diabetic ketoacidosis. They respond very well to insulin, and later on they become insulin independent and even respond to diet and oral drugs. So there is a recoverable beta cell dysfunction which occurs in this category of individuals. However, the exact reason for development of ketosis in these individuals is still not known. And there are various classifications which are available depending on the presence of beta cell function, C peptide, and the autoantibodies. Autoantibody positive, beta cell function poor, or autoantibody positive, beta cell function good, or autoantibody negative, and beta cell function is good, or beta cell function is poor. So A plus, B plus, A minus, B minus, A plus, B minus, like that. Variety of classifications are available for this kind of diabetes, but it is quite rare. The main chunk, that is type 2 diabetes in the young, we all know that it is increasing. This is the ICMR Young Diabetes Registry, 22.8% of youth diagnosis of type 2 diabetes. Southern India, type 2 diabetes incidence is 20.2 per 1,000 person years among adolescents over a period of 7 years. And as per Comprehensive National Nutrition Survey, 12.3% in boys and 8.4% in girls between 10 to 19 years of age, there is prevalence of dysglycemia. So it is quite high and it is increasing alarmingly. Screening should be done with overweight or obesity rather than BMI. You have to follow the waist circumference. That is much more relevant in our population because we might be having normal BMI, but we will be carrying more amount of fat in the viscera abdomen. So waist circumference is much more required. And as Dr. Rakesh has also done research that waist circumference that is more than 50% of your height, that gives you a clue that this individual at high risk of developing metabolic syndrome and various problems. If there is a history of diabetes in first degree relative, or there is a clinical evidence of insulin resistance like acanthosis nigricans, PCOS, dyslipidemia, hypertension, or patient having history of GDM, then these are the patients where screening should be done. And patients who are on antipsychotic medications or steroids and they are having obesity, they should be screened for diabetes. So this is acanthosis nigricans, we all know. Strong family history, generally both parents, they are having diabetes, and the children, they start developing diabetes in their 20s. Respond to OADs for several years, autoantibodies are negative, C-peptide is good, and presence of severe risk factors are there. The important point is beta cell decline, function decline is very rapid in these individuals, so they require insulin much early. Complications are much more in this category of individuals because of the longer duration of diabetes, and this is particularly high in adolescent girls than in adolescent boys, and therefore you have to be very careful. This is about beta cell failure. It is much more in people who are developing type 2 diabetes at early age as compared to those who develop at conventional age, that is 40s and 50s. Nutrition advice, I think it will be mainly based on reduction in total energy intake. Low nutrient energy dense foods should be encouraged. Eliminate sugar sweetened beverages, more fruit and vegetables, reduce saturated fat, include more of MUFA and omega-3 PUFA. Adequate knowledge of carbohydrates should be given, and there should be offered education on shopping, healthy meal preparation, and food labels, because these people, they indulge in outside eating, so they should be encouraged to learn more about healthy food choices, regular meal times. That should be education should be given to these individuals. Physical activity recommendations, minimum of 300 minutes per week of moderate intensity exercise, and less than 2 hours per day on screen time. So that is must for these young individuals, make them more physically active and less time on screen. I think few slides are missing. So metformin is the drug of choice, followed by insulin. There is an evidence for liraglutide, that in younger children between 10 to 18 years of age, you can use liraglutide. And yesterday only this news are released that dapagliflozin is approved by FDA for children with type 2 diabetes between 10 to 17 years of age. You can use dapagliflozin for management of type 2 diabetes in children, and it is based on this trial where DAPA and Sexa was used in this category of patients. DAPA showed significant improvement in A1C, but sexagliptin was not associated with significant improvement. And probably based on this, this has been approved by US FDA. So DAPA also you can use in children between 10 to 18 years of age having type 2 diabetes, in addition to liraglutide, insulin, and metformin. This is about 18 to 13 years of age and type 2 diabetes. HbA1c target should be very tight. Insulin at the initial stage if the patient is having symptomatic hyperglycemia. Metformin is must. GLP-1, SGLT2, DPP-4 you can use, particularly in girls or females. If you are using them, then you have to counsel them about contraception, because these agents, they are not approved for use during pregnancy. Patients having CKD, multiple severe risk factors, or albuminuria, you have to consider the use of SGLT2 or GLP-1 agonists. A word about double diabetes. This is also increasing now globally. The patients demonstrating features of both type 1 and type 2 diabetes. There are various hypotheses which are being given about this, but it is beyond the scope of today's lecture. There will be presence of type 1 diabetes clinical fractures, type 2 diabetes clinical features in the form of obesity, hypertension, dyslipidemia, and there is beta cell autoimmunity along with insulin resistance and obesity. So this is hybrid diabetes. This is also happening in young. This is the algorithm. If there is a positive family history present in 3 generations, there is no ketonuria, C-peptide is good, responding to OHA, then it is MODY. You have to go for genetic testing. If it is present, not present in 3 generations, but there is positive family history, ketonuria is negative, C-peptide is good, response to OAD and family history of diabetes in one or both parents, then this is early onset type 2 diabetes. If there is no family history, ketonuria is positive, C-peptide is absent, then it is type 1. It can be either autoimmune positive or autoimmune negative, autoantibody negative. If ketonuria is absent, C-peptide is poor, then you have to go for abdominal X-ray. This can be FCPD. If it is occurring first time in pregnancy, then it is GDM. If there are other features of endocrine disorders, then it is endocrine diabetes. And there are other features of genetic markers or mutations, then it is genetic disorders of diabetes. So insulin is the key to success as far as diabetes in young is concerned. Unless and until you have proper diagnosis, you have to start with insulin and continue insulin. Later on you may use metformin, gliptin, and if required even sulfonylureas and GLP-1 you can use for management of type 2 diabetes. You have to screen for microvascular complications. That is very common in type 2. That is very common even in MODY, some types of MODY and type 1 diabetes. So that is to be done regularly, either 5 years of duration of diabetes in type 1 or at the onset of puberty, and then annually nephropathy, retinopathy and neuropathy screening should be done. Whether they should be screened for macrovascular disease or not, that is still a question of research and debate. So to conclude, I say it is a heterogeneous disorder which requires proper classification and then proper management. All are not having type 1 diabetes. People may be having type 2 diabetes, FCPD or MODY. You have to follow simple tool assisting that accurate clinical history with simple physical signs, detailed pedigree chart, appropriate use of C-peptide, autoantibodies and genetic testing, and use of an algorithm that will help you decide the type of diabetes, and depending on that you can treat them and you can give proper glucose control and life free of complications. Thank you very much.
Very interesting topic and very latest. Even one of your slide you showed what was declared yesterday, like
yes,
use of DAPA in pediatric patients. Very good and very great learning for all of us. It is open for discussion.
No, there is no data to support the use of sulfonylurea. There is some trials to support the use of DPP-4 inhibitors that may prolong the requirement of insulin therapy, but sulfonylureas, there is no evidence.
Even, but I would differ slightly because DPP-4 again would be tricky in any pancreatic condition. So,
Pancreatic condition definitely, but he is talking about LADA.
okay, sorry, I thought you were talking about FCPD. Okay.
No.
LADA is okay, yes, fine. For initial 6 months,
FCPD you have to avoid
I just misheard.
Yeah,
I misheard
incretin-based therapies are better to be avoided.
Dr. Pratap, this side.
Yes.
So, if we talk about diabetes in young below 35, the latest paper that we came up with, RSS.
Yes.
So that shows a very high prevalence.
Very high prevalence.
And I think the rising prevalence is largely because of type 2.
Type 2.
So even
Definitely.
in our own practice, if we see and if we look at the diagnosis of consecutive 100 patients below 35, majority will be type 2. And very few will be type 1. So probably the numbers which are published earlier by SGPGI and the registry of ICMR, they might be older numbers, or probably there is a bias in the sampling because most of the people will register only a type 1 as young diabetic. Type 2 as young diabetic, people probably do not register that often.
That might be a clue. So I think Defeat Diabetes campaign, which was done by RSSDI, and the data analysis published by Dr. Rakesh only. So it gives a very good insight into diabetes in young. So I think prevalence is to the tune of almost 30 diabetes in young.
It was 17% below 35 years. But the thing is that our data was data from camps, where most of people, they come there already diabetic or family members of diabetic. The interesting finding that came out was, if you have a family history of diabetes, then you getting diabetes below 35 is 40%.
Yeah, that was 4 times higher as compared to 10% if you have no family history. So just having diabetes in one of the parents, I think we need to start screening much early in the offspring from their 20s only. Then and then we will be able to pick them at an earlier stage and try to prevent diabetes.
Yes. Thanks.
Thank you, Rakesh, for that comment.
Thanks for nice presentation. So I have 2 small questions. One is, how common is the lean type 2 diabetes mellitus in young? And the second one, have you noticed any increase in the incidence of type 2 diabetes mellitus after the COVID?
So after COVID, diabetes incidence has gone up. There are several literatures which are available. I don't know whether it is because of direct impact of COVID or some other issues, or the use of rampant use of steroids which were done across the country during that wave. That is very difficult to say, but definitely the diabetes has increased, and most of that is type 2 diabetes, which is increased after COVID. Regarding your first lean type 2 diabetes, I think that is still area of controversy and research. So probably a lot of work is being done in eastern part of India, where they are trying to find out lean people having type 2 diabetes like features, and there is some role of hepatic, some enzymes. Professor Siddharth Das has done a lot of work in that. That is malnutrition modulated diabetes. Previously it was being considered as, now they consider it as lean type 2 diabetes. But still it is an area of research, and I have not much idea or clinical experience of that entity.
So regarding COVID, so we also did a study.
Yes, you people have done a lot of work.
So a lot of work in COVID for diabetes, and you rightly pointed out in young also. And there was a direct affliction of pancreas to the tune of 25% because of the viral. And that has been published, and it has been internationally validated also, that there was viral affliction of the pancreas in almost 1/4 of the patients. How many had developed diabetes because of that, that is a secondary question, but pancreatic involvement was seen in almost 1/4 of the patients.
I think we have seen many people who say that they develop hyperglycemia during COVID wave, and later on they reverted back to normal glucose tolerance.
That was one part transient diabetes, but there has been an increase, overall increase in the diabetes after COVID.
Thank you.
For sure.
Okay.
I think the time is over and we can conclude the session.
Thank you.
Thank you to all the speakers and our chairpersons. We'll move to the next session. which is a case-based panel discussion on insulin regimens, moderated by Dr. Amit De, and the panelists are Dr. Dinesh Agarwal, Dr. Mayura Anand Kaile, Dr. Srihari Kulkarni, and Dr. Utkal Kadanga. Please, may I request you all to please come on the dais. Thank you.
So we'll be having a very interesting case-based discussion about using insulin in various cases. And I welcome all our panelists, Dr. Mayura from Aurangabad, Dr. Dinesh Agarwal from Guwahati, Dr. Kulkarni from Bangalore, and Dr. Utkal Kishore. I don't think he has reached yet. Is he here? He's just reaching. He's en route the venue from the airport. So what we will do is, we will take 3 of your cases first, and when Utkal comes in, then we'll take his case. All right, so over the next 40 minutes, what we're going to do is, we're going to give 4 very interesting cases, and each of them has been allotted a case, and they will be taking us with evidences from the scientific literature and the guidelines that we have, as what would be the best way of approaching these individuals in terms of insulin therapy, initiation and titration. So the first case is going to be a case of GDM. Now, we had an extensive session on gestational diabetes a while back in the afternoon post-lunch. A lot of discussions about initiating insulin and the type of insulin. So the first case is for Dr. Dinesh Agarwal. So this is your case. You have a 32-year-old patient who has got Gravida 2, Parity 1, 28 weeks of gestation. Previously, the individual had normal OGTT during the first pregnancy. However, in this condition, she has been diagnosed at 26 weeks with GDM based on the OGTT. Currently, she's on MNT with diet and exercise. Her BMI is slightly elevated. She's 28. And her fasting blood sugar is 105. Postprandial blood sugar is 145. So now, this is a patient with 26 weeks of gestation, and you need to decide on the line of treatment. So the first question to you is, should this patient be initiated on insulin at this stage?
Yes, please to the next slide. If we talk about the various guidelines, whether it is a DRWA guidelines or International Diabetic Federation guidelines or American College of Obstetrician guidelines, they say insulin is to be added when medical nutrition therapy fails and the fasting plasma glucose is more than 95, and postprandial 1 hour more than 140, and 2 hours postprandial more than 120. Similarly, the IDF also says if the fasting is more than 19 and postprandial 2 hours more than 120. DRWA also says that in our patients, the fasting is 105 and postprandial 2 hours is 145 on medical nutrition therapy for last 2 weeks. So she's a candidate for a good glycemic control and require insulin for the treatment.
The next question that comes is, what insulin regimen would you recommend in this case? You have the options of using a basal or a short-acting prandial insulin, or would you use a basal bull? Yes. No, patient is already on medical nutrition therapy. Already on medical nutrition therapy. Now, how would you proceed further? Yes. So this is the next question, Dr. Agarwal.
So it all depends on individualization of the therapy. We have to individualize whether if the fasting is high, we can start with the basal insulin, and if the prandial is high, we can have a short-acting prandial insulin. So if we talk about the guidelines, the ACUS, American College of Gynecology, says insulin analogs have been used in pregnancy which do not cross the placenta. IDF also says the rapid-acting insulins, Lispro, Aspart, or which have been shown to be safe in pregnancy. And the DRWA says it is ideal to use human insulin, which are least immunogenic. And we all know that designer insulin, Aspart and Lispros are better, which are fast acting and causes less hypoglycemia and better absorption. So we would like to use where the postprandial is high. I would recommend to use prandial insulin. If the fasting is high, it can be a combination of basal insulin also.
Yes, and I think we now also have some data about the safety of basal insulins.
Yes, true.
Yeah, but in this case, we would, since the patient just needs to be started on insulin, patient is not, it's a GDM. So our choice here would be starting with the prandial
insulin. So choice will be prandial insulin for this patient.
The other thing that comes, when you have a patient, having a fasting of 105, PP 145, sometimes we've seen clinicians not initiating prandial insulin all the 3 times. You give it usually with 1 or 2 of the major meal because it's usually the post-dinner or the post-lunch spike. So what is your thought and experience on that?
Look, we need to check blood sugar. The recommendation is 7 times or 4 times. When we see the Cochrane review, it doesn't matter whether it is 4 times. It has to be a mix and match of 4 times and 7 times. And whenever there is a high postprandial to that particular individual, we can start with that or may not have a 3. So it has to be an individualization. The bottom line is that our patient should have a good glycemic control to the target of less than 90 in fasting stage and less than 120 2 hours postprandial.
Great. So now when we are trying to tightly control blood sugar in these patients, there's always a risk of hypoglycemia, and we know that overt hypoglycemia or severe hypoglycemia by definition can be detrimental both to the maternal as well as the fetal health. So how do you balance this risk while still maintaining that strict control?
Again, it has to be individualized, and hypoglycemia, it has been seen to vary with gestational week in type 1 diabetes, and similarly there are a recently published trial in 2022 by the UK single center trial. They have compared the weekly increment to the daily increment by 4 units of the basal insulin where fasting was high, and they found that by giving patient a chance to increase the dose, they have a better control of fasting plasma glucose and less of hypoglycemia. They have found a single incident of hypoglycemia in 105 patients, and low birth weight babies are not there, but large for babies are also not there. So good glycemic outcome they have seen, and good outcome of the babies were also seen in that studies. But that was a single center study. So we have to again individualize. We did not want a sugar level, and what we can do is the severe hypoglycemia, we can have to education of the family to the patient, and we also need education to the healthcare professionals, so we can give some time. And most of the time person doesn't come very frequently to us, so the role of diabetic educator is very much important there, where we can make our persons to call them weekly or every 3 days, whichever way we feel like, and educate them and then adjust the dose when required. And we should ask about the hypoglycemia, whether they have any episodes of hypoglycemia or symptoms of hypoglycemia, then to adjust the dose.
Yeah, and on this context, monitoring becomes the key. So a quick comment from you. You just mentioned about the 4-point versus the 7-point, and also a quick comment on the use of CGM in maintaining targets.
There are, it has to be again individualized. We can do 4-point and 7-point, but it's a cumbersome. In our Indian context setting, it's very difficult to ask our patient to do 7 points a time. Cochrane review says it doesn't matter whether we do a 4-point or 7-point, the results are same. And there are studies with CGMs that doing 1 day the traditional and then doing CGMs for 6 days. Then by this we can make our patients more accountable and more we can able to adjust the dose more frequently. And then there are no GDM guidelines that how much time percentage of we should have, but there is for type 1 it is there, you should have been the target range of 63 to 140
yes.
more than 70% of the time.
Yes, right. So the last question about this particular case, a case of GDM, is the titration and the adjustment. So how do you go about with that? How often do you titrate the doses in practical case scenario for our audience to understand, and what does the guideline say?
The Ministry of Health and Family Welfare, they say it should be adjusted every 3 days. If the person is not on the target, we can check every 3 days. And this is a dosing and titration guidelines which was published in JAPI 2017, when by seeing the blood values level, fasting and postprandial, we can adjust by incremental or decremental by 2 units or 4 units, whichever the way we say. And the next slide shows you the guidelines by the Ministry of Health and Family Welfare by Indian guidelines, where they says every 3 days we see, and if the person is not on target, we should increase the dose, or if patient is below the target, we can diminish the dose. They have recommended titration every 3 days.
Right. So I think that was a very interesting case, and I think our audience will be having some more comments or question on this particular case, and we'll come back in the discussion. So now let's go on to another interesting case, and this is something that most of us have experienced, managing steroid-induced hyperglycemia, especially during the COVID days, and we have Dr. Utkal from Bhubaneswar with us. So this is your case. You have a 56-year-old female who's been diabetic for 8 years, having hypertension and dyslipidemia since 9 years, admitted with chest infection and found to be positive for COVID, fairly good renal function, average lipids, blood pressure 132/78, and the patient has got blood sugar of fasting 82, postprandial 140, A1C average 7.8. She's on glimepiride, metformin, sitagliptin, canagliflozin, rosuvastatin, and telmisartan, kind of a typical case. But this patient is now going to be given steroids because of the COVID infection. So the first question is, right away, should this patient be started on insulin, and what is the evidence is in favor of that?
So the meta-analysis says that the patient, any patient on steroid, 35% is developed steroid-induced hyperglycemia, and 20% is they come into steroid-induced diabetes. And a patient who is already on OHS and good control, and now going to start IV steroids, and the data says that, and also the experience, the blood sugar goes up. And it's because once steroid is given at the level of the liver, there is increased hepatic gluconeogenesis. At the level of the pancreas, there is destruction of the beta cells and insulin insensitivity. And at the level of the peripheral muscles, there is reduced glucose uptake and lipolysis occurs at the fat. So all this put together increases the blood glucose levels. So without any doubt, we have to put insulin here. And with OHS, it will be very difficult to control, even though we may double the dose, but we will not achieve the blood glucose control because blood sugar used to go was very high.
Yes. The next question is then, what type of insulin would you consider starting this patient, keeping in mind this diurnal variation in glucose levels? And I think during the COVID times, we've all experimented using NPH and basals. And then what is the recommendation and guideline? And along with that, there's another question for you, is that how would you adjust and titrate the doses of the insulin and synchronize that with the dose of the steroids? For example, if it's a intermediate or a long-acting steroid versus a short-time acting steroid.
That's what. The type of insulin we start, it depends on the steroid we're using. In case of prednisolone, the duration onset is 2 to 3 hours.
Yeah.
And for this, the ideal insulin will be like short-acting analogs or human regular insulin. But in case of methylprednisolone, the duration of action or the peak is in 4 to 6 hours. So for them, we can give a intermediate acting insulin, NPH, or we can give a basal insulin, or even premix insulin. And in case of dexamethasone, the peak is 8 to 10 hours or 10 to 12 hours. For them, always better to give a long acting insulin. So once, in this graph I have shown, once I was starting with this thing, short-acting steroid and giving it once a day, the ideal insulin will be once a day insulin, rapid-acting analog or regular insulin. And we check a blood glucose maybe in the lunch time. If the blood glucose is more than 200, then we can increase the dose by 2 to 4 units. And then again in the night time, if another dose of steroid is given, then we can put a short-acting analog at that point. So we have to keep on titrating every day, in fact, because patient is in ICU or in the IP patient going on increasing the steroid dose, so we have to check blood glucose at least 4 times a day and decide the insulin dose in the next day and monitor accordingly. And if the patient is getting as I said, methylprednisolone, and here the peak is 6 to 8 hours, the ideal insulin would be NPH insulin here, or a basal insulin given once a day, or else we can give a premix insulin twice a day. And they can check blood glucose 4 times a day and adjust the dose accordingly. And I just said, with a ultra long acting, this steroids, we can give a basal insulin, which is like, and the preferred insulin will be like the ultra long acting insulins like degludec or U300 or U100. And again, if there is sugar is high at any point, we can give a correction bolus with a insulin analog, rapid acting analog, and control the glucose.
So the last part has been usually our experience during the COVID time, because there was a rampant use of dexamethasone, and we usually timed it using an NPH or even a basal insulin in that case with the dose of the steroid, and we saw how it peaked. And then you added a prandial insulin to correct the postprandial spikes. And what we normally see, in fact, even in hematological patients getting steroids, is that besides the rise in the basal level, there is always a postprandial spike, and that is the most difficult thing to control in steroid-induced hyperglycemia. So sometimes you need to give an added prandial insulin along with that. So the next question again is, what are the considerations for the insulin therapy if the steroids are tapered or discontinued? And this is very important, because what happens, the patient is getting steroids in the hospital, and when the patient is discharged, the doses are tapered down or switched into lower doses of oral steroids, and usually physicians skip in titrating the dose of the insulin, and they go back home with the same insulin, ending up in hypoglycemia. So what is the recommendation?
Right, once we're reducing the steroid by almost 50%, so we have to decrease the insulin dose by 25%. And again, for the reduction of the steroid by 50%, we have to reduce by for the 25%. Till we stop the insulin, steroid, we can gradually stop the insulin, and again we can start with the previous OHS.
Right. So what is the frequency of the blood glucose monitoring? It has to be realistic as well as practical. In hospital, of course, we can do it 7 points, or we can even put the patient on a CGM. But what about back at home when the patient is still coming back at home with steroids? So how do you monitor and how frequently?
So here, if the patient is not a diabetic and patient comes and starting a steroid, patient A1 is less than 6.5, and the blood glucose, like you have to check once a day. If it is within 200, it's fine. We have to keep it checking every day. But if it goes beyond 200, we have to check 4 times a day and start with the insulin therapy. But if the patient is already a diabetic and A1 is more than 6.5, we have to keep checking at least at 4 points, like before breakfast, lunch, dinner, and bedtime, and give the insulin accordingly.
Just before we end this case, we've always seen patients getting hyperglycemia because of steroid, patients who are not having a history of diabetes. How would their management differ from a patient having a coexisting diabetes and going into dysglycemia?
For them, like, as I said, if A1 is less than 6.5 and you start the steroid, and the blood glucose goes up beyond like above 200 on 2 or more occasions, we have to start insulin therapy. We have to continue insulin till the steroid is given, and once steroid is stopped, we can stop insulin.
Yes, right. So that was again another interesting case, and we can always come back on the discussions on that. The other interesting section is starting, initiating, and titrating insulin in hospital setting, both in critical care setting and in non-critical care setting. So we have a case for Dr. Kulkarni here. So your patient is a perioperative case in this case, and 55-year-old male, type 2 diabetes for 10 years, has been admitted for a CABG surgery, and the patient previously was on metformin and sulfonylurea. So during the hospitalization, the patient in the ICU, of course, was stopped, all the oral agents were stopped, and patient was put on insulin infusion. Now, post-surgery, you're seeing the blood glucose level is somewhere between 180 to 220. So below 180 is our target in the hospital states, above. So how do we approach this particular case? The first question, 2 important questions, the perioperative management. That is, how do you manage the insulin therapy in the perioperative period while trying to control the hyperglycemia, still avoiding that hypoglycemia, which is very, very important? And what are your target blood glucose levels for inpatient post-surgery?
Perioperatively, most of the CABG patients are, admitted 1 day in advance. It's not a sudden admission, so we always plan the admissions for CABG, and previous day he is on rapid plus bolus. And perioperatively, normally these patients are taken up for the surgery early in the morning. So normally in our setting where I work, we take up the patient at around 6 a.m. and the patient is started on a rapid acting infusion. If the sugars are less, we start with a normal saline and a rapid acting, and even perioperatively the patients are monitored every 1 hourly. GRBS is done in perioperative.
Yeah. And what are the glycemic targets?
The target in a perioperatively it should be less than 140. In non-ICU setting, we can have around 100 to 180, and in selected patients, most of them should be about 100 to less than 140. In severe old patients and severely chronic kidney patients, we can have a more relaxing target of about 250, less than 250.
Okay. So now when you're transitioning this patient from IV insulin to subcutaneous insulin, so when and how should the patient be transitioned? And what insulin regime would you recommend upon stabilization?
See, most of the CABG, the day 2, we wean off from the ventilator on day 2 and day 3. Early morning, we shift to the subcutaneous insulin. Or when the patient sometimes is delayed, we start, when the patient is taking a oral fluid, we shift to the subcutaneous insulin. So how do we shift from IV to subcutaneous? First, the thing is we need to check the HbA1c on admission. If the blood glucose on day 3 is less than 150, it is only correctional dose what we need to give. One important thing is even on the day 3, we need to keep monitoring the GRBS ideally every 2 hours, in some patients every 1 hour. So if the GRBS is less than 140 or above 140, it is only correctional insulin. If the sugars are between 140 to 200, we add 0.4 units per kilogram body weight. And if the HbA1c is more than 10 and blood glucose is around more than 200, we add 0.5 units per kilogram body weight. And we divide it 50% as a basal and 50% as a bolus insulin. And per se, the basal bolus regimen is the preferred regimen. It has the physiological way of glycemic control, and nowadays we do not use sliding scale. It is outdated.
So now when the patient has got a good control in-house and you're planning the patient for discharge after stabilization, how do you determine the appropriate insulin regime at discharge? And most importantly, what education and follow-up care is necessary? I think this is a part which is mostly missing, which is not imparted by the nursing team or by the in-house medical officers when the patient is actually getting discharged. So,
see, the ADA recommendation for patient on discharge, if the HbA1c is less than 7, we discharge with the oral medications or with whatever the patient is on, if at all he is on insulin due to other comorbid conditions. If the HbA1c is between 7 to 9, oral agents plus a basal insulin. If the HbA1c is more than 9, it will be oral agents plus a basal bolus insulin. Most of this CABG, as I said, in most of the hospitals, we have this planned discharge. We plan the discharge on the 1 day before we plan the discharge and the treatment 1 day before. See, most of the patients, one advantage with CABG patients are that they are not in a hurry to go. Unlike other patients where, they want to, sir, we want a discharge today, but CABG patients are more compliant. They want to stay at the 7th day, till 7th day. So one advantage we take with this is we educate the patient. We have an educator, it is a must. And planned discharges are, it should be done.